Hello, everybody, and welcome to another Coffee Talks on Personalized Prevention from the Prophet Project. My name is Borislava Nanieva. I'm the EPF Capacity Building Officer. And today I'm very excited to welcome Professor Stefania Boccia from Italy and to discuss a bit further on the topic of personalized prevention. Stefania, would you like to introduce yourself?
Thank you. Good morning, and good morning, everybody. I'm Stefania Boccia. I'm professor of hygiene, preventive medicine, and public health at the Università Cattolica del Sacro Cuore in Rome, where I also serve as the head of my department of public health and life science. And I also serve my hospital as the deputy research director. My research topic have always been dealing with personalized medicine, in particular with prevention. And I have to admit that with public health genomics, since almost 20 years, that really gave me a sort of, basic knowledge and awareness about the relevance of the topic of prevention with the lens of public health, but also being aware of the capacity of the new technologies that drive in genetics, but also on the large amount of data that we can use to, stratify population into subgroups that can probably need more targeted approach in prevention, not only in curative care. All this knowledge accumulated in the past 20 years provided me with the capacity of having a research project funded from the European Commission as coordinator, which is Prof. And I had the chance to work with 18 partners. It was, I have to say, a big journey. I've been working with great partners, and we ended up with publishing a roadmap for personalized prevention and a strategic research and innovation agenda that covers a large amount of topics. So we are not here to discuss this, but if you're interested, go on the website of Prophet. You will find the links to the SRIA, the roadmap, and you can read more.
That's perfect. Thank you. Indeed, a very big topic. That's why we're trying to kind of break it down into a little bite-sized pieces for our audience to kind of understand in a lay language, what does it mean, how to get introduced, and so on. So with all your expertise, I'm sure that you're the perfect person to talk to about this. So can you explain a bit more in a lay language, what is a genetic passport in general?
Okay, so a passport in the sense of more pharmacogenetic passport, because this is the topic we're talking today, because a genetic passport itself does not really exist, but a pharmacogenetic passport, which is, of course, a passport that contains information on variants, on common variants of some genes that can influence the response to drugs. So if I have to say in a laid down language, a passport that contains genetic information relevant to the assumption of a certain drugs is something that do not exist as it is in Europe or worldwide, but exist some examples like in the Netherlands, in UK, but in the other countries, this is a discussion ongoing because a pharmacogenetic passport ideally should be something that is provided to everybody, to all the citizens before they take any drug. So this is why it's a passport, okay? So it's something that really can drive well before you have a prescription of a drug and information to a physician that is able to interpret how the common variants in your genome can influence the response to a drug, which means that you can really benefit from the drug, or maybe you can benefit from the drug, but at a different dosage. Not the same for everybody, you know? Why? Because some people have a different capacity driven from their genome to metabolize some drugs, to metabolize food, to metabolize alcohol. Everybody knows, no? They do not respond in the same way. If I drink a wine, I mean, I react in a completely different way from others. This depends also on the capacity of my genes to metabolize. It's better if I do not drink wine anyway, just small amount, maybe nothing is much better, but still, this is the same for drugs, okay? And if I know in advance, and it's not something that is related to hundreds of genes, today we know that clinical guidelines suggest that only a dozen of genes should be tested with no more than overall 50 variants. So it's not so much, you know? So clinical evidence suggests that only 50 common variants influence the capacity of response to drugs. But there are also people that, because of these common variants, have very severe reactions. So 1% of the people can react very, very bad to drugs and have a very severe reactions. So for these people can be really life-saving, knowing in advance the path, of these variants. So a passport is a sort of an information that should be contained in the electronic health record, ideally. Okay, this is something that is common in many European countries. So you go in a hospital, you go to the general practitioner, they have all the information of you in electronic health record. Okay, so if this information is there, then you don't have to communicate to the doctor when you're hospitalized or when the general practitioner prescribes a drug. Okay, I have to remind you have these variants. No, because it's contained in electronic health record. So they know a priori that they have to check and they have to communicate to you, okay, this drug works for you or not. So this is the passport, but it's not still there in the vast majority of the European countries.
Yeah, I can understand. That's what we were discussing with your colleagues as well, that of course in Europe it really matters which part and which country, because it varies quite a bit. And at the same time, I'm also wondering how long does this take to do? Because then I know that usually genetic tests, they take, let's say, a few months or something like this. So if I need to start some medication and I go to the doctor, and then they tell me, oh, first we need to do this, and then, but I need to urgently start the medication. How do I proceed in a case like this?
No, this is the genetic test itself related to a specific medication is not complicated to do. It's only, I have to say, probably it's only a couple of weeks. Of course, it depends. It depends from many factors. Just to take example of Italy, which I know much better than other countries, but if you live in the north part of Italy or even in the center part, this can be so easy. You don't have to take too much, because there is the capacity of the lab in the big hospitals, in the also research hospitals, to do it too quickly, because they have the next generation sequencing machine to make this very quickly. But if you live in the south of Italy, which might be similar to other European countries, you don't have the capacity to do the test at all, or you have to wait a long time because the sample has to be sent to another reference lab in another part of the country. So there is a huge heterogeneity, okay, in the European member states. So some countries perform very well, some others, but because of these big projects, 1+ million genome projects, all the countries are committed to make as a priority the capacity to do the minimum requirements for this kind of test, because these can be very much life-saving when it comes to taking drugs, especially in oncology. Some oncological drugs can have very strong side effects if you don't know which is your genetic background. It's only some examples, okay, like fluoropyrimidine, which is a drug very commonly prescribed in oncology, and there are guidelines for the test of the PYD. It's a very specific test. Not all European countries, not all the, unfortunately, all the regions in the different countries have the capacity to do, although clinical guidelines are there. So we have to admit that still we have to do better.
Of course. And I'm a patient myself. I have 3 kidney transplantations, and I've been taking immunosuppressive drugs for 21 years now. And as a patient that has been on quite a severe therapy, it's not something that you take by the way. I never, until I learned about the Prophet project and until I started doing the interviews, I never knew that a test like this is even possible, because after, in my first transplantation, I had a rejection episode of the organ because I developed a toxicity from the medication. So I'm sure that this is something that could probably have been avoided, if I had the right tests done and if everything was done accordingly. But again, as you said, I don't think this is very common or very popular, let's say, in the different European countries, because I'm originally from Bulgaria, and I don't know if they do these tests at all there, to be honest.
Yeah. Unfortunately, this is a situation. There are variants in the HLA and also in the cytochrome that really influence the answer to many drugs. So it's very likely that if you knew a priori, you would never pass through this horrible journey of rejection of whatever the therapy. The immunosuppression therapy is certainly very strong therapy, but 20 years ago there was nothing about that. But now it is. We had, I don't know if maybe this can be relevant also for the next question, because we know now that the physicians are much more aware about the capacity of predicting the response to the drugs, but themselves, they admit that they need to be trained. So themselves, they do not feel confident. And the oncologist much more, okay? But the general practitioner really asks to know more because they feel it's so relevant and they need to have a sort of basic, knowledge. So probably we need something like online pills of education to physicians, because it's not about hundreds of drugs or hundreds of genetic variants. It's so limited today, but that limited knowledge they have to know, and they admit that they don't know that much.
And where do you think this should be coming from? Is it the national bodies? Is it the medical curriculum where they study medicine? Where do you think it should be coming from, this type of education?
I think it's a great question. Okay, so first of all, medical education in the curricula. But this is something that it's already there since a decade. The basic pharmacogenetic knowledge, I think it's in all the medical curriculum since quite a long time. The problem is that since when they study and then they start the practice, things change and they can even forget. So this is something that should be very much reinforced when they start the postgraduate school specialization, okay? And this, I have to say, I think it's not heterogeneous. So it's very heterogeneous. So in oncologists, they do a lot. I don't think they do that much in the other medical specialty. And the general practitioner too. They are very curious, but they don't have a structured course in the GP postgraduate school. So in Italy, as example, we have an inter-society group. So there is the Italian Society of Pharmacology and the Italian Society of Human Genetics that established a group to develop curricula, develop a postgraduate course, endorsed from the Italian Agency of Drug. So I think it's very much up to the member states. They have to organize themselves. So in the Netherlands, they are super organized. So I think they can be sort of champion. They should explain to other countries, how did it manage? Because physicians in the Netherlands know that this stuff. So they can be a good example of how to make this concrete.
Okay, good to know. Who we need to reach out then for the good examples. So that's good to know. And can you explain that again in a bit more lay language? What are the benefits of the pharmacogenetic passport? You touched upon a little bit, but outside of let's say, reaction to different medications, is there anything else that can be seen there that could be useful for the patient long term?
Yeah. Okay, so if I have to give you some numbers, in Europe, on average, between 1 and 12% of the access to the emergency care are given to severe reactions to drugs. So it's huge numbers, okay? And this is something published, okay? So it's not numbers that I just inventing. Among oncology patients, 1% experience treated with drugs, chemotherapy, 1% experience a lethal effects. So 1% is a huge number. Up to 30% instead need to adjust the dosage because of interaction, of the genetic with the drugs. When it comes to the costs, a review of studies revealed that every adverse drug reaction costs more than 2,000 per patient that experience the adverse drug reaction, because it needs hospitalization, needs a number of adjustments. So it's huge efforts in terms of also funding from the hospitals. So also economically speaking, okay, from a strict economic point of view, using a genetic passport, but using also simply a genetic test when it's relevant before prescribing any drug, have the capacity to be not only cost effective, but also cost saving. So the system can also save money.
Mm.
So, I mean, evidence are very strong towards implementation of these tests. Ideally, as I said, a priori. So every citizen should know this. But at least before prescribing any drug, not waiting that the drug has an effect, which is not good to the patient, but before the prescription.
Mm. What you're saying, it makes so much sense, because then nobody wins if we continue doing the things as we're doing them now. The system, the healthcare system doesn't win, because then they're overwhelmed with all the patient. The patient himself, of course, doesn't win, because you can see all of the different side effects that might occur. The doctor's overwhelmed, the cost is too high, all of these things. So definitely something has to change in order for at least for there to be a win-win in some case.
I agree. But there needs
So
to be political commitment, so scientific society commitment, patient advocacy, which I think it's so important. Likely we live in Europe in a democratic way, and so we listen to this, okay? So sometimes politicians listen more to the advocacy of patients than the scientific society, and this is good, I have to say. And so everybody needs to be totally aligned, I think.
yeah, indeed, indeed. And from the patient side, I think it's definitely very important also to distribute this information within each other. So really to within the patient community to discuss about this, because then otherwise, as we mentioned, people are coming from different countries. In some countries, it's very, well accepted and very famous, let's say. In other countries, really not so much. So then if we communicate between each other as patients, and we have this health literacy, let's say, among ourselves. So what is available, what is not available, and how it can be done. We can definitely kind of boost, I think, this type of information. And as you said, it's really, I think, a holistic approach that all of us have to come in order to make a difference in this. So fingers crossed. I really, I really hope that it happens in a much bigger way across Europe, because it's definitely something that specifically patients can really benefit from in the long term. Because we're talking also about the quality of life. It's not only the treatment itself, but it's also the afterwards, the quality of life of the patient.
Yeah.
So my next question is, how and where can the average person and patient find more information about this and potentially do the actual test?
Okay, so where can find information? General practitioners. General practitioners add some knowledge because there are those that in the laydown population are the one more commonly prescribing drugs. So they know because it's written in the leaflet of the drugs, okay, that some drugs can have different effects depending on the genetic background. Limited drugs, okay? It's not about all the drugs that are used to be prescribed from the GP. So they know before they prescribe a certain specific drug that can have some side effect. So first of all, I think the best way to do is to ask a GP. Of course, if you are an oncology patient, you have to ask your oncologist. So the question is, are you sure that I can take this drug without any side effect? Because I know that this can be a problem. And if you are not reassured from his answer, probably you have to ask your GP back and forth. And now, luckily, we have a lot of information on the web. Also, find some information, advocate yourself before they prescribe any drug, okay? Because you cannot study medicine. If you're a lay-down patient, it's impossible, but you can advocate yourself with the GP or with the oncologist. It's very important.
Yeah, that sounds good. And it's also something that we're trying to make our patients realize that they can be a part of their own treatment and of their own journey. They just have to really, research some information, which I fully understand. As a patient myself, I can confirm it's really the last thing you want to do when you're already going through a treatment, when you're already sick, when you're already going to the hospital, is the last thing you want to do to try to find also some answers for yourself. But if the doctor, as you said, you speak to your healthcare provider and they say like, oh, I don't know about this, bring the information to them, tell them, hey, can you please check or something. If again they refuse, find another doctor maybe because
Yeah, exactly.
in this case I don't think you can afford to continue with this. And okay, so you go to, let's say, the relevant healthcare provider and you discuss with them. And even if they don't know, you bring them more information. You ask them to research, you ask them to check.
Yes.
And hopefully you manage to get the test and have really a safe use of your treatment. Do you know if there are any EU member states that would reimburse this type of
Yeah, sure. Yeah.
test?
Okay. The Netherlands for sure. In Spain, in UK. Okay, it's not the member states, but it's in the political
Yeah.
area of Europe. Italy, not all of them, which is incredible.
Is it a regional
Yeah, I
situation?
mean, yeah, it is. I mean, in Italy, there is not the capacity for region to decide in terms of reimbursement of drugs. This is something that is in the essential level of care. If a drug it is reimbursed or whatever intervention is reimbursed in the sort of list called the essential level of care, this should be done in all the regions. Then on top, a region, if it's rich, like Lombardy, Piedmont in the north of Italy, they can also add something, okay? But first of all the southern region are required to reimburse all the drugs if they are in essential level of care. For the pharmacogenetic, unfortunately, only limited numbers are in the essential level of care, which means that these limited numbers are reimbursed. For all the others, other regions in Italy reimburse, but others not. This is a big problem, and we discuss it a lot with the government, with the Ministry of Health, that they should very quickly introduce all of them in essential level of care, because it's not fair that people living in the south have a different a way of being treated with the people of the north. And so I think it's a similar situation in other European member states, but this is not exactly my field of research, so I cannot answer 100% sure which are the other countries that reimburse this prescription today.
Yeah. But it's good already that you mentioned that even in the same country, it can be quite different from region to region. And I think it's more or less the same, to be honest, in the different EU member states, because I can already, because of my condition, I had to get like a genetic test to see that potentially if one day I have children, will I carry, is it a gene that I carry with me? You see what I mean? And here in Belgium, it was reimbursed. And then I know that in Bulgaria, if I try to do something like this, it would not be reimbursed. So again, it's very broken up. There is no, let's say, European guideline. There is no European legislation to say this is important. It should be reimbursed for every patient that is starting. I understand, of course, not for every single one, but as you mentioned, there are some disease areas that are much more important to check this, like oncology, like cardiovascular disease. We talked previously with one of your colleagues, so definitely something to look into. And one of my last question is, what are the challenges in popularizing the genetic and pharmacogenetic passports? What do you think are the challenges?
Okay, so there are okay, we discussed some challenges so far.
Yeah.
Reimbursement is certainly one of them. But also, I have to say that from a citizen perspective and a patient perspective, there can be some challenges related to the privacy, the concern of the privacy, because it's a genetic test, okay? And from the literature, from Prof, we learned that some citizens and patients express are reluctant, okay, to make a genetic testing, also if it's about their therapy, because they're reluctant about the way in which this information is used. I mean, from one perspective, they're curious and they want to know because they are worried about the results of a drug that is not working for them. But from the other side, they are worried also about the fact that this information can be used from not trustable institutions, not trustable subjects. I think again that information, like it's the same for a healthcare professional. They need to be trained more, especially at the postgraduate level. I have to say that this is the same for citizens and patients, especially citizens. They need to know more about the use, about the meaning of pharmacogenetic passport, about the right to have this information when they are sick, but before them, because when they're sick, sometimes it's too late because you have to track the drug so quickly and you don't have time. So it's so important that citizens know that it's about their health. And sometimes you don't have time to do this when you're sick. And understanding the value of the genetic testing for them, for their family, and trust about the institution that they have to inform what they do with these genetic test results is stored in a very secure way. In Europe, we have such a strict regulation. So we have the GDPR, we have a lot of reinforcement because of the genetic information. So we are so lucky to live in Europe, okay? And we have to trust, I think, the institutions. But the citizens need to be informed. So you cannot think that they trust because you are a good hospital. You have to be informed about what they do with the results of their tests. So I think, again, citizens and patients need to advocate, need to ask, okay, what do you do with the results? I need to know exactly the information where is stored, who have access. And if, as it should be, the access is given only to the physicians, why not to do the test? I mean, but they have to know this, they have to read it, they have to give the informed consent. And once this is clear, they should trust, I think. And so this is a challenge in my perspective, because we need to be good as researcher, as a doctor, to inform in the best possible way, in the easiest way, in the most comprehensive way, the citizens and patients about the opportunity and the challenges related to this genetic testing, not only about pharmacogenetic, genetic testing in general.
Yes, I fully agree with you, and I think that we already mentioned a few of the challenges. This is definitely one of them. Coming from the patient community and in the European Patients Forum, we see more and more that there is this insecurity about how the data is going to be treated, where it's going to be stored, who has access to it. So I think it's very important really to notify the patient when something like this is being done. Here are the benefits, here are the risks, here is how the information is going to be processed. You make an informed decision afterwards.
Yeah, can I tell you also other challenges? Other challenges also related to the information system, the electronic health record that today do not communicate in all the hospitals in Europe, do not communicate very well with the lab that produce the genetic test, because genetic testing sometimes are stored locally. So they're not available at the point of care, which is crazy. They should be available at the point of care. If it's not integrated with the electronic record, it's not useful, because it's useful only for the prescription you do in that moment in the hospital. But then if you're hospitalized in another hospital, in another region, 1 year after, this information is not there. They do not communicate. This is common in Europe, and it's crazy. So if you do this test, this should be in your electronic health record, and it should be available at the point of care. And so this is a challenge which is not related to, it's not something in charge of the citizen, but it's related to the capacity of popularizing this passport. If the information system make available this information at the point of care, you do once and you use for the entire life, because the genome doesn't change. And this is important, I think.
It is important, and already just discussing this, it's really driving me crazy sometimes, because even the electronic health record, it's not available in some of the EU member states. Just the electronic health record, let alone what is inside or what isn't inside. So we're really very scattered in very different levels from member state to member state. And I think that one of the reasons why we should all be on the same base level to move forward is also this, the prevention, because then otherwise we really just repeat everything that we've done so far, and obviously it's not good what has been happening so far.
Exactly.
So that's very interesting. Thank you so much. As a takeaway message, do you have anything that you want to share with the audience? So some of the previous takeaway messages were really to discuss with the family, to have like an open conversation with the family, to say, hey, did you know your grandma had cancer? Your, whoever, just for people to get also genetically tested to see if they have anything that they should take into consideration or so on. So this was one of the previous messages. Maybe you have a different one. What do you think?
Well, my take-home message is that don't feel frustrated, because there are people that really care of you. Also scientists, very commonly also are patients. But beyond that, they have a strong commitment to do well. And especially those working in public health, it's really their mandate to make things working, and decision makers talking with science. Do your job, however, because you don't have to be passive. I think you have to be active, empowered, use only trustable information, and try to speak with your GP. If it's not good, change it. Okay, you can change your GP. And go to trust, also talk always with trustable doctors, okay? Because especially in the youngest generation are very much aware of the right of the patients, of the citizens, and they are very, very up to date. And go to research hospitals. There are many research hospitals in Europe. They have the mandate given from the government to do and to use the most updated therapy and preventive care. And so if you have the capacity, go there if you are in trouble, because really, I mean, don't be, I don't know what to say, don't be passive. It's not a world where you can be passive. You have to be active. And European Patient Forum, I think, helps, no? Because this is, I think, a good example, no? To reach the patient, giving the most up-to-date information on a certain topic, which is new, no? To some extent.
I agree fully, and I think that in today's day and age, everybody has the smartphone. Even already, if you're in the hospital, even if already you're getting the treatment or something, the easiest thing you can do is even if you just Google, pharmacogenetic passport or something like this. I'm sure that you're going to be drowning in information of what to do, how to take, and so on. So that's a very good message. Thank you very much for joining me today.
Pleasure.
It was a pleasure to talk to you. And join us again next time for the next coffee talk, where we'll be discussing more about personalized prevention.
Perfect.